Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Today we're exploring fertility. This includes what lifestyle changes or medications you can take before considering assisted reproductive technologies. When should GPs refer patients to a fertility specialist? And an example of a challenging fertility case. We also discuss other aspects of the fertility journey. This podcast is sponsored by MJA Fertility. MJA has been helping create families for almost 4 decades. Their world-leading IVF science and technology delivers success rates consistently higher than the national average, ensuring your patients have the best chance of a healthy baby. Referral and patient resources can be found at janaya.com.au. Dr Alice Huang is a highly experienced gynaecologist and MJA fertility specialist with a passion for personalised evidence-based care. Dr Huang is dedicated to providing individualised treatment plans for her patients, balancing medical and surgical options through a holistic approach, and she joins me now. Dr Huang, when is it appropriate for GPs to refer patients to a fertility specialist, and how can they best prepare patients for that referral?
That is a very good question, and one that I get asked very often. We can consider this from the medical definition of infertility. So the medical definition of infertility is not achieving a baby after 12 months of unprotected intercourse in younger women under the age of 35, or after 6 months of unprotected intercourse in older women over the age of 35. And this is because we know that 80 to 90% of our couples trying for pregnancy do fall pregnant within the first 12 months of trying. And also we know that delayed assessment and testing of older women can significantly compromise their chances of successful pregnancy with fertility treatment. And so GPs can often initiate a referral to a fertility specialist after a couple reaches the definition of infertility. But I do think that GPs don't always need to wait for a couple to reach that criteria before referring to a fertility specialist, because a fertility conversation is appropriate at any time that the couples need. This can include preconception health discussion before they start trying. This can include advice on how to try with timed intercourse while they're trying, or even discussions about testing and treatment options if they do struggle when they are trying. For a guide to my GPs, I usually talk about observations of natural fertility. So if I have a couple with no fertility issues, 80% of the time they should conceive within the first 6 months of trying. And that's regardless of age. And that's quite important to remember, 80% within 6 months. So if they don't conceive within 6 months, it doesn't mean that they can't conceive at all, but it does mean that the chances decrease after that. So if they have been trying for 12 months, the chances of falling pregnant after that is 15%. If they've been trying for 2 years, the chances of conceiving after that drops to about 5%. So the longer that they tried to conceive, the lower the chances of falling pregnant actually becomes. And that's sort of a mathematical calculation certainty, because if the chances of falling pregnant was higher to begin with, then they should have fallen pregnant earlier. So the longer they try, the lower the chances are. So in my opinion, I do think it's reasonable to seek fertility advice from fertility specialists and fertility testing after 6 months of unsuccessful trying for pregnancy, because 80% of the couples should conceive by this stage. In older women, I actually think that's very reasonable for them to seek further testing and discussions after 4 months of trying, because it might be good to get baseline information earlier. And if they do need fertility treatment, then we don't undue delay that. In couples with predisposing risks for infertility, so women with things like polycystic ovarian syndrome, with irregular periods or history of chemotherapy or pelvic inflammatory diseases, sexually transmitted infections, or male partners with sexual dysfunction or testicular surgery or sexually transmitted infections, I always recommend a fertility discussion with a fertility specialist early. In regards to preparing patients to see a fertility specialist, I think GPs consider a few things for both partners. For the female partner, I think it's very good for GPs to encourage them to keep a menstrual diary so that they can keep an eye on how often they're having their periods. So if they are abnormal, irregular periods, the GPs can actually arrange things like hormonal profiles or blood tests for things like FSH, follicular stimulating hormone, or LH, luteinizing hormone, or ovarian hormones like estradiol, progesterone, androgens like testosterone, DHEA, thyroid hormones, prolactin. That can all be very helpful. A pelvic ultrasound for the woman is also quite helpful to rule out uterine or pelvic pathologies like polyps or fibroids that can compromise the chances of falling pregnant, and also an ovarian reserve quantification. So that's an AMH blood test usually. AMH doesn't predict her chances of falling pregnant, doesn't predict her fertility, but it can give that baseline information about her egg quantity, which can impact on decision for timeline to testing and treatment for this couple. And for the male partner, the GP can consider semen analysis. So generally speaking, if there is no sexual dysfunction in the male partner and the semen analysis is normal, that effectively can rule out about 90% of male factor infertility.
What are the most common lifestyle changes or medications you recommend before considering assisted reproductive technologies?
So the common lifestyle changes I recommend before considering assisted reproductive technologies or fertility treatment is health and weight optimization. So being underweight or being overweight can both decrease fertility. It can also be associated with increased adverse events in pregnancy. So it's better to be healthier before they fall pregnant. And I usually talk to my patients about living a healthy lifestyle. Usually what holds true is what's good for general health is good for fertility health. So the four main things I usually talk about is diet, exercise, stress, and sleep. Most couples are quite good at diet and exercise, less so good at stress and sleep. So from a diet perspective, there's no definitive data on which diet is best for fertility. And I think in reality, it's not a one-size-fits-all kind of situation. But it's generally accepted by most specialists and dietitians that the Mediterranean diet, so that's the one that's high in fresh vegetables, plant oil, and low in animal fats, low in processed sugars. So that Mediterranean diet is generally accepted to be beneficial for fertility. From an exercise perspective, also no definitive data about this, but general recommendation is about 2 to 3 hours a week of moderate to high intensity activities. Moderating stress is also very good for general health. It's good for mental health. It's good for building resilience, and also getting a good quality 7 to 9 hours sleep every night is also very beneficial to optimize general health. And of course, we should consider decreasing or cutting out toxin exposure, so things like smoking, alcohol, caffeine, illicit drugs. That can also help with fertility.
How should GPs communicate realistic timeframes and expectations to patients undergoing fertility treatments?
So managing patients' expectations for timelines and treatment outcomes is one of the most difficult parts of my role as a fertility specialist. So I would expect it's not that easy for the GPs as well. What I do with my patients is we need to be honest and upfront about the fact that fertility treatments can take multiple cycles to achieve a pregnancy, and sometimes it can result in setbacks, and that chances of success is lower in older women. There's always so many unknowns in someone's fertility journey. So, even though IVF or fertility treatments are very good ways for us to bypass obstacles to fertility, so it's helping us speeding up the time to get to a successful pregnancy, we will never really know the outcome until we get there. And so it's very common to find that fertility treatment can be physically, emotionally, and financially demanding on the patients. But they need to be aware that they are not alone in this, and that support is available from their GPs, from counsellors, from the fertility specialists. And so I think the key point is to focus on what we can control and try not to get bogged down in what we can't control during fertility treatments.
Can you provide a case study where early referral made a significant difference in patient outcomes?
So I recently saw a couple with secondary infertility and recurrent miscarriages. So she was 37-year-old and they had a son 3 years ago naturally. They started trying for a second child about 2 years ago, and unfortunately has had 4 miscarriages in those 2 years. And that's often the hard part about the secondary infertility. They often have had the first child quite easily and then unexpectedly struggle with the second child or subsequent children. And there's that reluctance to see specialists, a reluctance for discussion about treatment options because their first child was so easy to conceive. And so this couple, they were seen by several other gynecologists and a recurrent miscarriage clinic. But like so many other couples with recurrent miscarriages, there was no cause found for the miscarriage. And they were becoming quite frustrated, or they're progressing through the recurrent miscarriage clinic and seeing different specialists doing different tests, and that was just dragging out the time from when they started wanting a second child. So her GP suggested having a chat with a fertility specialist instead. And after we met, after discussion, we decided that the most direct, the fastest route is just proceed to IVF with something called PGTA. So that stands for pre-implantation genetic testing for aneuploidy. And that's where we can create embryos with her eggs and his sperm. And then we test the embryos to ensure the embryo has the correct amount of genetic material, so chromosomally normal, before we put the embryo back into the uterus. And so this woman underwent a first egg collection, and it only resulted in one chromosomally normal embryo. But she did fall pregnant with the first embryo transfer of her one and only normal embryo. And I was very excited. I just did a pregnancy scan last week. I was very excited to see that little embryo growing well in the uterus, and that first sort of healthy heartbeat sound on scan. Was they still have a long way to go before giving birth, but I'm very happy for them, and just can't wait. Really wanted to share this with you.
What are some of the lesser known fertility treatments that GPs might not be aware of, and how can they discuss these options with patients confidently?
So most GPs are aware of IVF and what it involves, and IVF, whilst it's a very effective fertility treatment, it's not the only fertility treatment options. So we can consider things like treatment for other pathologies that can directly compromise fertility, so things like endometrial polyps, uterine fibroids, endometriosis, that can be treated surgically, and that can all be beneficial to fertility in some women. Other fertility treatment will include ovulation induction, especially in women who don't ovulate regularly, so like women with PCOS or polycystic ovarian syndrome. So during ovulation induction, we give medication to induce ovulation. And then for my patients, I track them with follicle tracking scans or ultrasounds in my rooms to confirm that they are ovulating. And I can guide them on when to have intercourse when I see signs of ovulation on the scan. There's also IUI, so intrauterine insemination. And that's another option. So that's when we do ovulation induction to track ovulation. But then on the day of ovulation, instead of having intercourse, we laboratory collect the semen or the sperm, and we concentrate that down to just about 0.5 mils or half a mil. And then I can inject that concentrated drop of sperm directly into the uterus. And so this is often done for single women or same-sex couples when they're using donor sperm treatment, or for couples with mild sperm abnormalities. I think GPs can gain confidence by being aware of these options. They always have the option of speaking with fertility specialists as well, so dial a friend situation. And many of my GP colleagues do that. They give me a call to ask about their particular patients before giving that advice to their patients. And also they can attend professional developmental seminars or even listen to podcasts like this one to increase their confidence. I think that GPs can confidently discuss these fertility treatments by framing them as additional options available if the couples fail to conceive naturally.
Are there opportunities to raise fertility conversations with patients when they don't present with a fertility concern?
Yes, so fertility discussions can be initiated during routine health checkups or consultations. So, for example, when they're discussing family planning or contraceptive options, it's a very good opportunity to talk about fertility. I think GPs can also start conversations about fertility preservation, so things like egg freezing, particularly in patients when their age is nearing their 30s, if they don't have any imminent plans to have a baby, or if they have conditions like endometriosis that can sort of cause issues with fertility in the future. And even for those already having fertility plans but about to start trying, the GPs can often have that conversation with them about preconception counseling, genetic carrier screening testing, health optimization strategies, etc.
In what ways do emotional and psychological support play a role in patient readiness for more advanced treatments like IVF?
We all know that there is an emotional toll from fertility treatments and the fertility journey as a whole, especially when a couple struggles to fall pregnant and just don't conceive as soon as they think they should. So I think GPs can provide psychological support, refer patients to fertility-focused counsellors. Is a very good revenue. They can encourage couples to manage stress, and I would often encourage them to try and manage stress as a couple, to be there for each other. And it's good for emotional well-being, and it can often influence how, if they do need fertility treatment, often influence how well they can cope with the stresses of fertility treatment. And that can in turn influence their outcome for pregnancy. It's really important, I think, for GPs to remind the patients that, fertility treatment is a journey, so that, emotional support through counseling and support groups can often help them maintain resilience and build up that arsenal of skills that they can use to help them get through.
Can you share an example of a challenging fertility case and how the treatment plan evolved?
So I can recall a patient of mine who came to me a few years ago. She's just had a dilatation curettage or DNC after a miscarriage with another doctor, and she needed IVF. And we did a few cycles of IVF unsuccessfully, and we were concerned because it was her age that was most likely the reason for infertility. So we decided to move on to IVF with donor eggs, to see if we can increase the chances. So once we've had that lined up, she started donor egg IVF. Unfortunately, I had to cancel her twice because the changes on her uterus wasn't as we would expect. So during an IVF cycle, to prepare the uterus for the embryo to go in, we would like to ideally see the uterine lining thicken up to sort of develop and prepare itself for embryo to implant. And her lining stayed thin. It just refused to grow despite additional hormone support, additional medication. And so we went from struggling with an egg issue to now looking at the uterus issue. And to investigate, I did a hysteroscopy, which is a camera to look inside the uterus, and unfortunately found a very severe scarring or adhesion, most likely from the DNC, from the miscarriage, which is not a common, but it's a recognized complication from any miscarriage procedure. And she had what we call Asherman syndrome. So that's a very severe form of adhesions where the entire uterus cavity is obliterated by this scar tissue. So it's good that we found it. It's good that we haven't put an embryo with created from donor eggs in that uterus. And I was able to divide the adhesions and normalize that uterus cavity at the same procedure. And after she recovered, we sent her off again to restart IVF with donor eggs, and very luckily she fell pregnant with her first baby. And then a couple of years later, her obstetrician sent her back to me because she found some new adhesions that had formed, or new scarring that had formed inside the uterus. That was a complication from her baby delivery. And so again, I did another hysteroscopy. Again, I found some adhesions. Again, we divided it and normalized the uterus. I said, okay, we'll wait for you to heal, and good luck. Hopefully you get that second baby with the donor eggs. And a couple of months later, I received a very happy message from my patient to say that she actually fell pregnant naturally without donor eggs after uterus recovered. So that was very lovely to hear, and just tells me how weird and wonderful nature is, and how every woman is different.
Thank you to my special guest, Dr Alice Huang. This podcast is sponsored by MJA Fertility. MJA has been helping create families for almost 4 decades. Their world-leading IVF science and technology delivers success rates consistently higher than the national average, ensuring your patients have the best chance of a healthy baby. Referral and patient resources can be found at janaya.com.au. You can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thanks so much for listening.